Hello, everybody. Today I will talk to you guys about how we implemented our head and neck patients and an Sgrt together. So I will talk a little bit about our clinic, about the Sgrt devices we have, what we do with them, and then I will go on to the head and neck treatment, as we started this whole project with a very interesting case, and I will tell you how we implemented, how it looked, and what data we have so far. So this is our clinic. At the moment, we have 4 Linacs, which 3 of them are conventional Linac, and 2 of them have the Sgrt device. The first system was already installed in 2015, and the second system we have since 2016. We are currently using the device for almost every treatment. We started with our breast free breathing, moved on to DIBH, basically all our SGRTs, but also our normal thorax and abdominal treatments. We will use our Sgrt device for extremities, including boluses. We use it now for head and neck patient, and we had some unique cases where we had no mask for head and neck patients, where I'll come back on later, or patients who do not want it to be touched, or positioning of very hard structures where we had to, where we could use the Sgrt device very good for. But today I will focus on the head and neck patients. The first time we were actually thinking about this was we had a patient, and after a few times of trying to make a mask of her as she was coming to the planning CT on different days, trying again, had medications to calm her down, but still there was no way that she could bear the mask. She had too much of claustrophobia, and she just couldn't do it. For her personal opinion, there was no option for a surgical resection, so we had to find out another way to treat her. So what we thought then is, oh, we have this device, maybe we can use it. This is really a unique case. This is not something we would like to standardize, and this is also a very compliant patient, which was very aware of the effects that it may have, but also aware that this was her last real good option for treatment. So what we did is that we made sure that there was some kind of stability you can see under her head. We made some personal cushions, so we were already aware of where her shoulders and her head position should be. And then we used the system for further positioning, but most of all for monitoring. So this is how it looked like. I think it's also good to say that the volume was small. There were no lymph nodes involved, so a small volume which we could monitor very well. And that is also what we saw. We saw that the beam was held when our 3 millimeters threshold was reached. What we also tell our patients with such small volumes is that if they could not swallow, and this is a clinic decision, but what we saw is that even though we ask a patient to not swallow during treatment, patients do swallow. It's probably hard for them, it's not so easy. And what we saw is that during this motion in the patient, the surface of the patient moved so much that it would reach outside of our tolerances, and that the beam was held in these cases. So this patient was really happy that we could do her treatment, that she had a way of help, that we had found a way of helping her, and this brought us to an idea. So why would we not have a more open face mask approach? Not get rid of the masks, but a little bit more open could already help a lot. We would assume that it would give a way much better patient comfort. We are aiming for a comparable setup with closed mask. We do not want to reduce any imaging. We can monitor our neck region for swallowing motion, or maybe coughing, or any other motion which may be there during treatments, which we do not know of. And maybe there's even a case where it would be interesting if we could see some weight loss during treatment. So then the question was, are we not already using kind of an open face mask? Because a lot of patients complain about the mask. In the beginning, it's it's most of the time okay, but then they start also chemotherapy. They get a lot of fluid in their bodies, and still they need to do their treatment on the day or the day after, where they're still a little bit swollen of other medications maybe, and then they have so much pressing points. So sometimes the only solution to that is to open up the mask more so they can bear the mask and we can complete our treatment. Well, these are our normal standard masks, so you can see that it's just a really small opening where the patient has space to breathe. And then we found, well, we wanted to be more open with the mask, but with the system we have, there's not an available open face mask. And before we start introducing in the clinic a new mask system, which would cause confusion, we thought about why do we not make it ourselves first. So now we made sure that the face is open, so up to the eyebrows till almost the ears and under the nose. So the chin is in the mask that makes the mask stable. And then before we actually make a CT scan, we also cut out a neck area where we later on can monitor. So this is how we would make the mask. We would start putting the mask on, and this would be the end result. And at this point, now we can make actually our CT scan. So what we did is that we would screen the patients, only patients within treatment site where no lymph nodes were involved were included. And we would first generate the CT scan when the mask was completely open, and then we would import this data set to our Align-IT system, and preferably any treatment without any bolus. So this is what we would see during treatment and setting up. So the patients come to our treatment, we would drive our table to the ISO center by the saved values, and then we would start setting up our patient with the phase ROI. On this phase ROI, the aiming of this ROI was to make sure that the big rotational roll and pitch movements were ruled out. If we were happy with that, we would go to our neck area ROI. In this ROI, we made sure that every translation and rotational was as close to 0 as possible. After that, we would generate our co-beam CT and shift based on that. When the shift was done, we would make a new ROI and we would monitor the neck area during treatment, whereas as soon as there was any movement, the beam would stop. So we divided in 2 groups. We had 7 patients in each group. We evaluated our post-match shifts, and for the patients who had the Sgrt device, the open face mask, we also evaluated the intramotional fraction of the intrafractional motion. This is data which we had never had before. We tell the patients not to swallow, not to move, but are they actually laying still in their masks? Every patient was treated with 16 in tube arcs, and it was 20 to up to 34 fractions per patient. So if we look at the data, we compared the shifts based on the co-beam CT with the closed mask and the open mask. Again, I would like to say that the aim was to have a comparable setup, not to have a better setup. There's no need to, we do not want to reduce imaging. So what we can see is that it is very comparable. The closed masks are the purple ones, the open masks are the green ones. And we see that using the Sgrt device, we have less outliners. It's for most of it in the translations. And we see that if you do not use it, that we have more outliners which are bigger. If we then look to the rotational movements, we see that the masks, open masks, are not particularly better, but still they're comparable. I come back on this later. So then it was also interesting to see if we compared our Sgrt device to the co-beam shifts. These are the vertical, longitudinal, and lateral shifts, and we can see that they're small, that if we set up on our surface, that also after a comb MCT, we're still not making big shifts. If we then look at our rotational shifts, they're quite much bigger. And I would like to explain why. First of all, the ROI. We made ROIs on our neck region, but as you can see on this one, here it's quite high up. And because the ROI was quite high up, the chin has been in the way of the ROI, which makes that the device cannot really see what's actually going on. Another thing is that it is quite different for our techs, for us to set up a patient like this compared to what we're used to. Normally, if we see that there is a shift necessary, we as RTTs move the patients in the right direction. We know exactly what to do, that's how we train. But in this case, we have a patient in a mask and we see that it's not correct. So we have to instruct the patient how to move, because in a mask, we cannot move the patient. That's something which requires extra training and extra visibility of extra knowledge of our RTTs, and I've seen in the clinic that with time that gets better. So then I come to the monitoring data. This is a data set which we got out of our Align-IT system, and I will explain to you what we see here. So the first bit where it's quite outliner, we see that that's the point where we put the patient on the table with the mask on. Then we see, well, this is not what we want. We drive the table or the patient to as close to zero as possible. We leave the room and then we tell the patients, please do not swallow. They probably swallow one more time. We wait a little bit, of course. Then say, okay, we're making the cone beam. Let the patient swallow again. Look at the images. And every time you see that in a longitudinal direction, there's actually quite a big shift. After we matched the image, we would shift, and that's the end here of this data set. So the results of the monitoring data. During beam delivery, we actually see that it is nicely in our tolerances most of the time, but if the beam stops because the patient moves, we see that there's actually a big shift in longitudinal direction. It's 4 millimeters, whereas our limits of the PTV margins are 3 millimeters. So actually, this is really nice that we can stop the beam here. And we even see that as soon as the mean maximum shifts during the beam hold are up to 2 centimeters. This is way too much for such a small volume where there's not been calculated for such a big shift. So what we can say is that using this system for an open face mask, it's comparable to our normal setup and we have more information. But what the best thing is that we assume that we get more patient's comfort out of it. At this point, we are more assuming, we get feedback from patients that it is nice, but to really make sure that it's better, we are going to start a phase 2 trial on patient comfort based on the open face masks. For the future, we would like to have better staff training. We would like to sit down together and talk about how we're going to let a patient move, how to instruct it to get better data. And maybe there's even a reduction of PTV necessary, because now we have seen that there's such a shift, but we can monitor it and the beam will stop during these shifts. And maybe in the future we can include patients with lymph nodes in the PTV. So this is what I would wanted to tell you tonight. Thank you very much for your attention.
Thank you very much for your nice presentation. Are there some questions? Yes, please.
Thank you for this nice presentation. I basically have 2 questions. The first one is it really clinically relevant to stop the beam when the patient is swallowing? And secondly, is it practically possible to hold the beam when the patient is performing a swallow movement?
The question if it's clinically relevant, I myself am an RTT. I cannot answer your question from a physicist or a doctor's perspective, but this is a clinical decision, but we only use it for such small volumes. As soon as there's lymph nodes involved, the PDVs get bigger, and then, no, there's no clinical relevance anymore. Can you repeat your second question, please?
The second question is, are you able to hold the beam before the swallow movement is over? So there is some delay, I think, in holding the beam, also from Align RT and also from the hardware of the Linac itself. So isn't the movement of the swallowing over before you hold the beam?
I think we can only really answer this question if we would image during treatment. We saw that this is the movement and this is the reason, but if it really is stopping the beam at the right times, I can't say because I do not have the imaging data for that.